So my name's Beth Littleton, and I'm in the Office of the Vice Dean in the Medical School here at Pitt. And I've been working with surgeons who teach residents, and in particular, trying to understand or help them teach more efficiently. Believe it or not, as technical and as intelligent as they are, teaching is not actually something that they're trained to do, so they need a lot of support, and they're very good at it, but they need help, especially for surgical procedures that are what we call blind, where there are blind steps that you do in a surgical procedure where you can't see where you're going, you can't see the thing that you need to see, you can't even put a camera in the place where you need to be cutting. So I have a colleague, her name is Amelia Diego, and she's a breast oncological surgeon. And she teaches her residents a number of procedures. The biggest one that she does is to try to excise, take out a lesion in the breast that might be or is cancerous when you can't even feel the lesion. You can't even, it's not even, it's like, it's so small, like 4 millimeters, and you can only see it on x-rays or on a mammogram, but you can't actually see it or feel it. So how do you get that out? You can't see it. So there's a procedure that she tries to teach. It's very, very hard to teach because the equipment involves placing a radioactive seed, tiny little thing, injected near where the radiologist has found this tiny lesion, so that then the surgeon can use a wand that detects acoustically where is that seed, and that's where I'm going to cut this thing out. That equipment is really expensive. They can't just kind of have people take, the wand and the seed and the rest of it and put it in a turkey breast and, practice, right? It's also thinking your way through it spatially is really hard, and it's extremely high stakes. So if you cut a little bit further away from the lesion than you should be, you're going to take out tissue that's going to make the breast cosmetically not as attractive after you're done. If you miss any of the lesion and the cancer, you don't get it out, that's a big problem. And for students, they feel like they watch their their surgical teachers performing this procedure, and they don't really know, they can't really see, they don't really know what the surgeon is doing to cut this out properly, and they're not really going to get a chance to practice. So what would be really nice is a way to visualize what a lesion would look like in the breast and be able to look all the way around it, or something so that the trainee has a little bit of practice moving that wand around and seeing where the lesion is. That won't harm a patient, take out more tissue than you should, not take out the right tissue. So yeah, so I actually saw for the first time this procedure being performed by my colleague, Dr. Diego. And it was very touching for me to for Dr. Diego to tell me a little bit about her. She was young, very young for someone going for this procedure. She has a particular gene mutation that means she has very high risk of breast cancer. Her mother has had breast cancer, and she was very sweet about, wanting someone to come in and observe the procedure so that they can teach it better for future patients like herself. And I think as she was just going under anesthesia, I think she told the doctor that I think maybe her sister had recently been diagnosed or something, and it was a very touching moment. And it really brought home the fact that here's this expert procedure that is so important to learn how to do well, and it's so important for patients that more surgeons can train in this area and feel like they can be really proficient in the area, so they go into this area and perform it for more patients. So yeah, it's a very touching moment.